This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 475 of our pharmacotherapy series, which majors in hematopoietic cell transplantation. In this video we will discuss the case of patient KBS from part 474 of this pharmacotherapy series. KBS will receive an allogeneic hematopoietic cell transplantation from his histocompatible sibling with the hope of inducing graft versus tumor effect to help in treating his malignancy. So my next questions to you read: what is the graft versus tumor effect? Which tumors are most responsive to this effect? Graft versus tumor refers to the phenomenon where the donor's cytotoxic T lymphocytes suppress or eliminate the recipient's malignancy. Initial clinical evidence of a graft versus tumor effect came from the observation that patients with graft versus host disease had lower relapse rates compared with those who did not. This suggested a graft versus tumor effect due to the donor lymphocytes. Lymphocyte involvement in graft versus tumor was further supported by the effectiveness of donor lymphocyte infusions in treating patients who experienced relapse of their malignancies after allogeneic hematopoietic cell transplantation. Eradication of the recurrent malignancy is due to either specific targeting of the tumor antigens or to graft versus host disease, which may affect cancer cells preferentially. Different illnesses vary in their responsiveness to donor lymphocyte infusions, with chronic myelogenous leukemia, abbreviated as CML, and acute leukemias being the most and least responsive, respectively. Patients with certain solid tumors, e.g., renal cell carcinoma, also appear to benefit from a graft versus tumor effect. These data are the platform on which the use of reduced intensity and non-myeloablative preparative regimens are based. What is the rationale for using myeloablative preparative regimens for patients like KBS who are to receive an allogeneic hematopoietic cell transplantation? What types of regimens are used, and what is recommended for KBS? The combination of chemotherapy and/or radiation used in allogeneic hematopoietic cell transplantation is referred to as the preparative or conditioning regimen. The rationale for high-dose myeloablative preparative regimens is similar to that discussed in the autologous hematopoietic stem cell transplantation section. Infusion of hematopoietic stem cells restores hematopoiesis induced by dose-limiting myelosuppression of chemotherapy, maximizing the potential value of the steep dose response curve to alkylating agents and radiation, and suppressing the host immune system. The preparative regimen is also designed to eradicate immunologically active host tissues, lymphoid tissue and macrophages, and to prevent or minimize the development of host versus graft reactions, i.e., graft rejection. Conversely, patients undergoing syngeneic transplantation do not require immunosuppressive preparative regimens before hematopoietic cell transplantation because the donor and the patient are genetically identical. Thus, there is no potential for host versus graft reactions. Therefore, preparative regimens are tailored to the primary disease and to human leukocyte antigen compatibility between the recipient-donor pair. Most allogeneic preparative regimens for the treatment of hematologic malignancies contain cyclophosphamide, radiation, or both. The combination of cyclophosphamide and total body irradiation, abbreviated as TBI, was one of the first preparative regimens used, and it is still used widely today. This regimen is immunosuppressive and has inherent activity against hematologic malignancies, e.g., leukemias, lymphomas. Total body irradiation is myeloablative and immunosuppressive, does not have cross-resistance to chemotherapy, and reaches sites not affected by chemotherapy, e.g., the central nervous system. The toxicity of total body irradiation and the scarcity of facilities for its delivery have led to the development of radiation-free preparative regimens. Modifications of the cyclophosphamide total body irradiation, abbreviated as CY/TBI, preparative regimen include replacing total body irradiation with other agents such as busulfan and adding other chemotherapeutic or monoclonal agents such as alemtuzumab to the existing regimen. These measures are designed to minimize the long-term toxicities associated with total body irradiation, e.g., growth retardation in children, cataracts, or to provide additional anti-tumor activity. The long-term outcomes of busulfan, cyclophosphamide, abbreviated as BU/CY, and cyclophosphamide total body irradiation in patients with acute myeloid leukemia and chronic myeloid leukemia have been compared in a meta-analysis of 4 clinical trials. Equivalent rates of long-term complications were present between the 2 preparative regimens, except for a greater risk of cataracts with cyclophosphamide total body irradiation and alopecia with busulfan, cyclophosphamide. Overall and disease-free survival rates were similar in patients with chronic myeloid leukemia, although there was a trend for improved disease-free survival with cyclophosphamide total body irradiation in acute myeloid leukemia patients. In the case of a mismatched allogeneic hematopoietic cell transplantation with an increased chance of graft rejection, antithymocyte globulin, abbreviated as ATG, may also be added to the preparative regimen to further immunosuppress the recipient. Based on these data, the cyclophosphamide total body irradiation preparative regimen is preferred for KBS, because he has acute myeloid leukemia with poor cytogenetics and has a matched sibling available. Because of the high relapse rates seen in acute myeloid leukemia, myeloablative allogeneic transplant is indicated in first remission for patients less than 60 years old with good performance status due to the decrease in likelihood of achieving a complete response to reinduction chemotherapy and the expected reduced duration of a second remission. Describe the rationale for non-myeloablative preparative regimens. Is KBS a candidate for such a regimen? The regimen-related toxicity of a myeloablative preparative regimen limits the use of allogeneic hematopoietic cell transplantation to younger patients who have minimal comorbidities. Because many patients with hematologic malignancies are older and have comorbidities, myeloablative hematopoietic cell transplantation cannot be offered to a substantial portion of them. The observation that patients with graft versus host disease have less relapses and an improved understanding of the graft versus tumor effect led to the development of strongly immunosuppressive but not myeloablative, i.e., a reduced intensity or non-myeloablative, preparative regimens. Currently, reduced intensity preparative regimens account for 30% of allogeneic transplants. More than 60% of patients receiving reduced intensity preparative regimens are older than 50 years. There is a wide spectrum of reduced intensity preparative regimens, with the non-myeloablative regimens causing the least amount of myelosuppression. In general, more intensive preparative regimens are required for engraftment in the setting of unrelated donor or human leukocyte antigen mismatched-related hematopoietic cell transplantation. Reduced intensity regimens do not completely eliminate the host's normal hematologic and malignant cells and therefore depend on the graft versus tumor effect to eradicate remaining cancer. The newly transplanted donor cells slowly replace host hematopoiesis and elicit graft versus tumor effects. After engraftment, mixed chimerism is generally present. Chimerism can be defined as the ability to detect both donor-derived and recipient-derived hematopoietic cells. Both donor and patient cells coexist together for a period of time in the patient. If the graft is rejected, typically only recipient cells are present. After a reduced intensity preparative regimen, mixed chimerism, defined as 5% to 95% donor T cells present in the peripheral blood, between the host and recipient develops, allowing for a graft versus tumor effect as the primary form of therapy. Chimerism is evaluated to monitor disease response and engraftment post-transplant. Chimerism is assessed within T cells and granulocytes in the peripheral blood and bone marrow using conventional, e.g., using sex chromosomes for opposite-sex donors, and molecular, e.g., variable number of tandem repeats for same-sex donors, methods. The methods used to characterize chimerism after hematopoietic cell transplantation are reviewed elsewhere. A few months after hematopoietic cell transplantation, donor lymphocytes can be infused, called a donor lymphocyte infusion, to augment the graft versus tumor activity. The use of donor lymphocyte infusions is dependent on the availability of the donor and is highly center-specific. The challenge is to maximize the graft versus tumor effect while minimizing the risk of graft versus host disease. Therefore, graft versus host disease prophylaxis, although different from that used with myeloablative regimens, is still necessary. Although reduced intensity preparative regimens have led to lower treatment-related mortality rates, they may be offset by higher relapse rates. The safety and efficacy of these regimens have led to their wider application to non-malignant conditions. Because most of the data for reduced intensity preparative regimens are derived from older patients or those with comorbid conditions, they cannot be compared with data for myeloablative preparative regimens. It is unclear if reduced intensity preparative regimens improve long-term survival of patients with malignant or non-malignant diseases who are younger or without comorbid conditions. Prospective controlled trials are needed with stratification based on comorbidities, disease characteristics, pre-transplant therapy, and hematopoietic stem cell source. There is a paucity of data regarding the optimal source of hematopoietic stem cells after reduced intensity preparative regimens. Most case series have combined data from peripheral blood progenitor cell and marrow grafts. But some data suggest that, compared to bone marrow grafts, peripheral blood progenitor cell is associated with quicker engraftment, earlier T-cell chimerism, longer progression-free survival, and a lower risk of graft rejection. KBS is young and healthy enough to receive a myeloablative allogeneic hematopoietic cell transplantation. Presently, reduced-intensity hematopoietic cell transplantation is only indicated as first-line therapy for patients ineligible for myeloablative regimens, due to age, extensive prior treatments, or other contraindications. It is not an option for KBS. My next questions to you read: what is the rationale for immunosuppressive therapy after an allogeneic hematopoietic cell transplantation? What is recommended for KBS? After infusion of hematopoietic stem cells, immunosuppressive therapy is administered to prevent or minimize graft versus host disease. Patients receiving syngeneic transplants or AT cell depleted histocompatible allogeneic transplant generally do not receive post-transplantation immunosuppressive therapy. In syngeneic transplantation, the donor and the patient are genetically identical, and graft versus host disease should not be elicited. In T-cell depleted transplantation, the volume of donor T cells infused into the patient is usually insufficient to elicit significant graft versus host disease. Numerous immunosuppressive agents given alone or in combination have been evaluated for the prevention of graft versus host disease. Commonly used regimens after myeloablative hematopoietic cell transplantation include cyclosporine or tacrolimus administered with a short course of low-dose methotrexate. Graft versus host disease prophylaxis varies in reduced-intensity protocols. Corticosteroids may also be used to prevent graft versus host disease, but they are more commonly used to treat graft versus host disease. In allogeneic hematopoietic cell transplantation recipients without graft versus host disease, immunosuppressive therapy is slowly tapered and discontinued over the course of 6 months to 1 year. Over time, the immunologically active tissue between host and recipient become tolerant of one another and cease recognizing the other as foreign, negating the need for immunosuppression. In contrast, solid organ transplant recipients usually continue immunosuppressive therapy for the duration of the recipient's life. In patients without a matched related or unrelated donor who undergo hematopoietic cell transplantation with a haploidentical donor, the use of cyclophosphamide post-hematopoietic stem cell infusion may be used. The cyclophosphamide is typically given approximately 4 days after hematopoietic cell transplantation. It has been shown that the cyclophosphamide does not affect the hematopoietic stem cells, but does exert its effect on all or active T cells, thereby reducing the risk of graft versus host disease development. Current trials are ongoing to assess the usefulness of this approach. KBS is receiving a myeloablative preparative regimen with allogeneic transplant and will receive cyclosporine administered for 6 months, followed by a taper, with a short course of methotrexate 15 mg per meter squared on day +1 and 10 mg per meter squared on day +3, +6, and +11 for post-transplant immunosuppression. This combination regimen will lower the risk of graft versus host disease. Assuming KBS does not experience any serious complications, he will likely be immunosuppressant-free by 9 months post-transplant. The cyclosporine will require therapeutic drug monitoring. My next questions to you read: how do supportive care strategies used for myeloablative preparative regimens with an autologous graft differ from an allogeneic graft? What supportive care will KBS likely require? Supportive care strategies common to patients receiving a myeloablative preparative regimen, regardless of whether they have received an autologous or allogeneic hematopoietic cell transplantation, include use of indwelling central venous catheters, blood product support, and pharmacologic management of chemotherapy-induced nausea and vomiting, mucositis, and pain. These similarities are a function of the side effects of a myeloablative preparative regimen. Because of the different needs for immunosuppression with an autologous and allogeneic hematopoietic cell transplantation, the supportive care differs. Allogeneic hematopoietic cell transplantation patients experience an initial period of pancytopenia followed by a more prolonged period of immunosuppression, which substantially increases the risk of bacterial infections, but more importantly, fungal, viral, and other opportunistic infections. The risk of infection increases as additional immunosuppressive therapy is incorporated to prevent or treat graft versus host disease. Supportive strategies designed to minimize infection during immunosuppression are essential after allogeneic hematopoietic cell transplantation. KBS received a myeloablative allogeneic transplant. Therefore, he will have a central venous catheter inserted at admission. He will most likely require multiple RBC and platelet transfusions until engraftment occurs. He is at increased risk of infection because he will be immunosuppressed for months after the transplant. Also, if he were to develop graft versus host disease, additional supportive care would be required. Graft versus host disease prophylaxis with cyclosporine and methotrexate will place him at risk for additional drug-related toxicities that will require monitoring. Had he received an autologous transplant, the duration of neutropenia would be less, no immunosuppressive medications would be required, and the risk of developing complications from graft versus host disease would have been avoided. My next question to you reads: how do supportive care strategies used for myeloablative and non-myeloablative preparative regimens with an allogeneic graft differ? A direct comparison of the toxicities between a myeloablative and non-myeloablative preparative regimen is difficult because the latter is offered only to patients who are not candidates for myeloablative allogeneic hematopoietic cell transplantation. The preparative regimens differ substantially in terms of the chemotherapy agents used and the degree of myelosuppression. Non-myeloablative hematopoietic cell transplantation may have a different time pattern for infectious complications, but there is a similar incidence and severity of acute graft versus host disease. This makes comparisons between the preparative regimens challenging because of the differences in the pre-hematopoietic cell transplantation health of the recipients. Clinical research is focusing on designing optimal preparative regimens with acceptable efficacy and toxicity. Thus, as compared to myeloablative hematopoietic cell transplantation, the preparative regimens and immunosuppression used after hematopoietic stem cell infusion are more variable for reduced intensity and non-myeloablative hematopoietic cell transplantation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 476.